Assalamu alaikum wa rahmatullah wa barakatuh. Dr. Musa Akbar, Dr. Abdullah Shahab, dear panelists, esteemed guests, and organization committee, thank you very much for allowing me to present this case. I am very happy to be among distinguished interventionists coronary here in Bahrain. Actually, it's cold either here or in the room. I switched the AC off all night. Anyway, good. It's not uncommon, actually. I would like to use the word, it's not uncommon rather than it's rare, complication of coronary intervention. It's a serious complications. Believe me, one time it will come and it will happen to you if you are doing coronary cases. At least it will happen to you twice or maybe 3 times a year. Why I'm presenting this case? So we have so many cases in Dubai Hospital actually with coronary perforation. But why I choose this case? Because this case is, I would like to talk about operator part of the perforation rather than the perforation itself. And confirming to have in your mind, first is the patient safety. Your aim is to get the patient out of the cath lab in a safe situation. And next point, I want to make sure that what is your next step? Once you realize there is a perforation, what you should do next? There is an algorithm for what to do next, but sometimes you don't need to follow that algorithm in your practice. So let's start with a 56 years old gentleman who came to Dubai Hospital in emergency department. He was having chest pain. So what we did is, we did this in ECG for him. So clearly seen there is an ST segment elevation with a Q wave already established in the inferior leads, providing there is a there is changes in the lateral leads, and there is some mild changes in the anterior leads. We did echo in the emergency department, and ejection fraction is around 40 to 45%. He was diagnosed in inferior wall ST segment elevation involving right coronary artery by ECG. His cardiac markers was highly raised. Let's go back to the ECG and find out. You can see ST segment elevation and some T wave start changes with established Q wave. So in your mind, you think this is more than 12 hours. In the cath lab, we did diagnostic left coronary injection, and it shows that there is mild irregularities in the obtuse margin circumflex. Proximal LAD looks fine. Left main also, but there is mild irregularities. In the RA code, in the RA or cranial view, and you can see there is a proximal, moderate to severe, and perhaps severe lesion in the mid LAD. Left main looks healthy, and there is a diagonal also. So we expect now that the RCA is totally occluded because ECG is having inferior wall myocardial infarction. So let's see the RCA. So what's happened now, you can see that the takeoff of the RCA is high. It's take up, not down. Usually RCA start and descend down in the groove, but this one, the takeoff is off. So, and there is mild, you see that when you drive a car and there is a dangerous mark where you give you the road has 2 bends, not 1 bend. We started with a BM wire to negotiate that lesion, totally occluded, but it seems it was difficult. So we changed to whisper wire with a minitric balloon with 1.5 sizes. Now, when you do an injection and wiring is going through the RCA or any coronary artery, and the distal wire looks awkward. It's big knuckling, number one, and it doesn't seem that it goes freely. You expect the lesions to be at least 12 to 15 millimeter, totally occluded, but after the lesion, which we crossed already, you think the wire will pass easily because it should go through normal lumen. So what happened? Stop. So what happens that, now I told you in the beginning, I'd like to talk from operator point of view. So he tried to push the wire hard, and the wire doesn't want to go or doesn't want to follow the path he expected to go. He used a small balloon and tried to manage with the wires. Now, he used a whisper wire, he added now pilot wire with this just to negotiate. That's my point is, this video is a bit long, but it tells you what's happening when you start getting panic. And you only concentrate on passing the wire, not the patient's safety. There must be something in your mind that something wrong is going on. Don't just want to cross the wire. To say, I know he's an acute myocardial infarction, his ejection fraction is expected, it's accepted, but this guy, or me, want to rush the wire hardly, then he want to start from beginning again. Actually, he was lucky, because next he will use a whisper wire, and the wire could pass through the lesion. Now, always, almost always, look at the distal wires movement in normal coronary or in any lesion. Who is happy about the distal wire movement? Well, it could be in the pericardium, yes, but it could be not. I cannot say, but most likely yes. So what he did, he put a balloon, short balloon, just to cross the region. Pushing it hard, without looking at the distal wire, how it behaves, then, oh, good, the balloon crossed. He's happy now, because he achieved his aim. He wants just to cross the region, not looking at the distal wires or where the wire is, should be. And after he was happy, he made an injection. Now, he saw this one. So what is the next step? There is a perforation now. It's not huge. If you see this in the cath lab, what is the next step? Can I ask the panelists? Just one word. What do you think the next step? No, not to explain because I need my time. I have only 2 minutes.
Block with put a balloon and block the...
Put a balloon. So you need to treat this.
Yeah.
Is there any retrograde?
No, no retrograde.
No retrograde.
Just this one. So
proximal, just proximal ballooning, Dr. Ahmed.
Anybody will do anything else? Wait for a while. Good. Okay, next, you know what he did next? Unexpected. He took another review. This is really what to do. Take another review and make sure wires are okay, everything's fine, in place. Then it will tell you what to do next. Okay, he took another wire, which is pilot 50. Because he thinks that the wire is in, when he took the other view, we discovered that we are not in the lumen. So let's take the other view and take another pathway. So what happened after taking next wire? Try to negotiate hard. Again, he went back to his own target, is to cross the lesion and to save the patient. And I think it's not bad, really. If he succeeded, he can do ballooning and he can put a graft stent. He got fed up, the operator. He took a long time. Then he wanted to see how bad. So at this time, why brotamine is given at this time? Because you don't want to give brotamine when items inside the coronary. If the wires or balloon inside the coronaries, don't give brotamine. It will thrombose. The coronary might thrombose. So he felt things are getting worse and worse and worse. I really want to stretch on one thing. Once you see even a tiny perforation, a small leak, my advice to you, this end my talk, get your pericardial safe. Put pericardiocentesis, don't worry. It will not kill the patient. Patient still hemodynamically can tolerate the procedures. And then you can work, or you can stop, or you can call the surgeon, you can put balloon, you can do whatever. Now you can go and negotiate the proximal, only RCA, and put the balloon. But you are safe. You secured your pericardium, because that one which kills the patient. So this is my point. Thank you very much.